Hello and welcome to episode 18 of CCLG's Research Talks for Parents and Public. I'm Ellie Ellicott and my job is to share research with our supporters. So starting with some housekeeping, we'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of one using the Q&A button, which is at the bottom of your screen. If you'd like to use the chat function, make sure you set the to drop down to everyone or people may not see your message. This webinar is being recorded and will be available publicly on our YouTube channel, and I'll send out the link when it's ready to watch. So this month's talk is called Fertility in Children with Cancer, Who is at Risk and What Can be Done? It's being led by Professor Rod Mitchell and Dr. Mark Brougham. Rod and Mark are part of the Edinburgh Fertility Preservation team, with Rod being one of the founders. Rod is an endocrinologist, which is a doctor that specialises in hormones, and his research focuses on fertility and cancer. Mark is a childhood cancer consultant and is involved with a range of research aiming to improve childhood cancer care and treatment. So without further ado, I'm going to hand over to them.
Okay, so many thanks for inviting us to talk this afternoon. As I say, my name's Mark. I'm one of the children's cancer doctors here in Edinburgh. So I'm going to start off talking and then Rod's going to talk about some of the exciting research that we have. As Ellie said, there'll be plenty of time for questions if there's anything you don't understand or anything you want to ask us for your help with. So we're going to talk about fertility in children with cancer, who is at risk and what can be done. Oh, this isn't advancing. Don't you love technology? Why is this not moving? I don't. Oh, is it that one? Try that one. Okay, so what are we going to go through this afternoon? Well, firstly, why fertility is important. What we actually mean by fertility, which might sound obvious, but I think it's important to consider what we mean by fertility and why cancer treatment might affect it. How we assess fertility, which is also not very straightforward, and the importance of discussing fertility. Then we're going to go on to who might be at risk of fertility problems in later life, and most importantly, what can be done about it. Both established techniques, so these are things that have been around for many years that have proven success, but we're also going to talk about some of the experimental things that are coming through that we hope we'll be able to use in the future. I'm going to mention briefly about sexual health and how that's different from fertility, and then say we'll have plenty of time for questions at the end. So why is fertility important and how important is it to patients and families? And I'm conscious that I'm speaking to people who will know this actually far better than I do. Obviously, if you have a diagnosis of cancer, then cure is the priority. We want to cure our patients, but we do need to think about long-term side effects. And that's really why we're talking about fertility today. I speak to many families at diagnosis, and I've heard many things over the years, such as when I bring up fertility, people say, well, as long as he survives, that's the most important thing. And of course it is. She can always adopt. It doesn't matter if she can't have children of her own. But actually, when we do studies looking at people that have had treatment for childhood cancer many years ago and they're now in adulthood, many of them actually describe that loss of fertility is one of the long-term side effects of treatment that actually distresses them and upsets them the most. So it is something we do need to pay attention to. Many people, when they're asked about what was offered at the time, many of them often regret not actually thinking harder about what could be done to preserve their fertility before treatment started. And what we do know from a lot of studies actually is that, sorry for background noise, what we know from a lot of studies is that many survivors actually reflect that there wasn't enough information given to them at the time, and there wasn't enough support and help in making the right decisions at the time of diagnosis. So what do you mean by fertility? Well, obviously we mean a sperm coming together with an egg to make a baby. Firstly, how can it be affected by cancer treatment, and why are we talking about it today? Well, sperm are produced in the testes, and we know that you need more than one sperm to make a baby naturally. You need enough sperm to get to the egg to fertilize it. And many cancer treatments can cause damage that mean that not enough sperm are produced. They may produce a few, but not enough to be able to conceive a baby naturally. In terms of females, eggs are produced in the ovaries, and some cancer treatments cause the ovaries to stop working earlier than normal, so that not enough eggs are produced, and therefore patients cannot have a baby naturally. So that's really what we're talking about. It sounds basic, but I think it's important to highlight. So focusing on males first, before puberty, boys obviously don't make sperm that can fertilize an egg, unlike males after puberty. But their testes do contain what are called spermatogonial stem cells. So I don't know if you can see my pointer, but a spermatogonial stem cell is like sort of the mother cell that goes on to produce sperm after puberty. And those are in the testes from birth. So boys before puberty have these stem cells. They will develop into sperm when they're older. Now, cancer treatment kills cells that multiply quickly. That's how cancer treatment works. So chemotherapy, radiotherapy is very, very good at killing cells that are multiplying quickly. But that is why we get the side effects of the treatment that we are used to dealing with. And obviously, if many sperm are being made, so after puberty, many sperm are made all the time, it's quite easy to understand why cancer treatment will damage those sperm being produced. But what we also know is that cancer treatment given to boys before puberty can actually damage the sperm stem cells, and therefore they're not able to produce sperm after they've gone through puberty. And that's where the damage comes from. So we need to think about how we can protect these stem cells that from which the sperm will develop when they're older. Now, the testes also has an important function of producing testosterone, which is the male hormone that will help you go through puberty and give secondary sexual characteristics. And cancer treatment doesn't usually affect those cells. So many boys who are before puberty who have treatment that can damage the testes, they may not be able to produce enough sperm to make a baby, but they should go through puberty normally, albeit some may need some hormone support. In terms of females, you may know that girls are actually born with all their eggs in their ovaries. So the ovaries are sitting down in the pelvis, and the ovaries contain all the eggs that you have for life, and these are obviously released after puberty once a month until they go down to a very low level. So this graph, I hope you can see it okay. This graph is age across the bottom and follicle number. So basically the number of eggs in an ovary. And before birth, actually they start to go down even before birth, but from birth all the way down to the average age of menopause, which currently is about 51 years old, the number of eggs in the ovary just goes down and down and down until it reaches a very low level. And once it's at a low level, the menopause occurs. And your optimal sort of time of fertility, that when you're most able to have a baby, is sort of between, in your sort of 20s to maybe early 30s, after which your fertility goes down. So that's what happens in any female. That's just a normal reduction of what's called the ovarian reserve. Now, cancer treatments kill off cells that are very active. So some cancer treatments can cause this egg reserve to go down faster than it would do otherwise. So say, for example, a girl has chemotherapy at about the age of 10, okay? Then instead of going down the black line, as it should do, some chemotherapy drugs may make the eggs go down faster. So the eggs go down, so perhaps in that, and this isn't a scientifically accurate graph, this is just a representation, maybe the eggs will go down towards the menopause level in their 30s rather than in their 50s. So that means that their window, their time to have a baby naturally is much more shortened than it would be otherwise. And that's really important because we know that many people want to have a baby later in life. Even over the last sort of 30 to 40 years, there's been a general trend of people wanting babies later in their life for other reasons. So it's really important that people know their eggs may run out sooner than otherwise. When we think about radiotherapy, if you have radiotherapy to the ovaries, radiotherapy can be very, very damaging to the ovaries. I'll talk about this shortly. So if you have radiotherapy to the ovaries at about the age of 10, again, your egg reserve may go down very quickly so that actually you don't have enough eggs to have a baby before you would even think about wanting to do that. So that's something that is very important to think about. So some chemotherapy and radiotherapy that includes the ovaries, so radiotherapy to the area of the pelvis, can cause the menopause to be early, which means, as I say, people may need to think about trying for a baby earlier than they would do otherwise. Or it may cause the ovaries to stop working extremely early so that having a baby naturally is not possible and other things need to be considered. And the menopause isn't just about having babies. There are other medical health issues related to the menopause. So people may need hormone replacement therapy for the other concerns that menopause may bring. So how can you tell if your fertility is affected? Well, you can assess fertility, but most of these things that I'm going to go through here are only really helpful if you've already gone through puberty and your ovaries or testes are working or not working. These tests aren't really very helpful before you've gone through puberty. So for men, for males that have gone through puberty, something that's really easy to do is to measure the volume of the testes. Now that's something that we can do with this thing in the bottom left-hand corner. It's called an orchidometer, and that's used in the clinic. And basically, it just gives you an idea of how many mils, how big the testes are. And if the testes are sort of in the orange, so sort of 15, 20 or 25 mils, that would suggest that they're producing good amounts of sperm. But in the yellow, if you've gone through puberty and then the yellow, the testes might not be producing enough sperm. We can do blood tests, checking the different hormone levels that control sperm production, so that could be very helpful. And actually, one of the most useful tests is actually analysing a sample of semen. So the person would produce a sample of semen, and then that can be sent to the lab to see how many sperm there are, because are there enough to be able to make a baby naturally, and how well do they swim? So these are really, really helpful tests. None of them are very helpful, unfortunately, until you've gone through puberty. For females, again, if you've gone through puberty, if your periods are regular, that's a really good indicator that the ovaries are working normally. Although it's important to remember that any cancer treatment can sometimes make your periods irregular for a time until they settle down and become regular. Again, the volume of the ovaries can be measured using, but unfortunately, because we can't see them, we have to use scans like ultrasound scans. And similarly to males, we can do blood tests checking hormone levels, which can be really helpful. And one of the blood tests we often use in females is something called anti-Müllerian hormone, or AMH, which is a very good indicator of how many eggs you have left in your ovaries. But it sometimes can be quite difficult to interpret, particularly if you haven't gone through puberty. So I guess what I'm saying is there are lots of ways you can tell if you're fertile, but before puberty, it's very, very difficult. The other really important thing, and I say this to all the people I look after who have had treatment, is never ever assume that fertility has been affected by cancer treatment. So if you do not want to start a family, it's really important to use contraception. So how about discussing fertility at diagnosis? So I have many discussions with patients and families when they've just been told they have cancer in it. I've not been in that situation, and I can't imagine how distressing that must be. There is an overwhelming amount of new information and new language to get your head around, both in terms of what is the diagnosis, what is the plan for treatment, how successful will that treatment be, what are the side effects of treatment. And many of you will have been told about clinical trials that people can go on, and that's a lot of information to weigh up in a very, very short space of time. So it may feel, with all those discussions going on, that actually talking about fertility that may be 10, 20 years in the future, it might not sound very important or relevant. But as I said at the beginning, we know that many people who have had cancer when they were young wish they had been given more information at the time. And there are things that can be done to help. So if fertility is going to be affected, there are things that we're going to talk about that can be done to preserve fertility. But these are all really important to do before any treatment starts, because once you've started treatment, even a little bit of treatment, that can have effects that mean that we can't think about preserving or protecting fertility in the future. So your healthcare team should absolutely talk about fertility with you unless there's a very good reason not to. And I say that because we do know that some healthcare teams are sometimes reticent and a bit worried about talking about fertility, but it's really important that they do talk about it with you. And if they don't, then I think it's important that you ask them to give information about fertility. So who is at risk of future fertility problems? Really, really important to know that not all cancer treatments cause infertility. Do not assume that because you're receiving cancer treatment, you will therefore be infertile. That is not the case at all. I would say actually the majority of children we look after do not have problems with fertility in later life. Still important to discuss it though at the beginning. It's also difficult because much of what we know about fertility is assessing fertility in people who've received treatment many, many years ago. So we can't guess what treatments might cause infertility. We only know that by collecting data and collecting evidence on people that have had these treatments. And as you're aware, the treatments that we give today are very different from those we gave 10, 15, 20 years ago when people have had them and can assess fertility. So it can be very difficult to accurately guess accurately assess who's going to be at risk of future fertility problems. Thinking about the types of treatment that we give for cancer, so surgery, a surgical operation to remove a tumour should not affect your fertility. The reason why I mention this is because some surgery might involve removing a testis or an ovary. So if you have cancer in one of your testes, that will almost certainly be removed with an operation. But we know from studies that if you have that, your other testis can compensate. So you should be able to produce all the hormones you need and produce enough sperm. So removing a testis should not affect your fertility, although you do need to look after your one remaining testis. In terms of removing an ovary, if you need an ovary removed because of cancer treatment, again, the other ovary should be able to compensate. And also sometimes, as I'm going to come to, we sometimes remove an ovary to actually preserve it for future use to make a baby, leaving the person just with one ovary left. And interestingly, even though what I've said about your ovarian reserve going down over the period of your lifetime, if you remove one ovary, people who only have one ovary don't seem to have a significantly earlier menopause, so their other ovary definitely seems to compensate to a large degree. Chemotherapy is obviously a big part of cancer treatment, and as you probably be aware, lots of different types of chemotherapy are given. It's very rare to give just one chemotherapy drug. There's usually 3, 4, 5, sometimes more different types of chemotherapy drugs that are given, and most of those are given because they kill off cells that are multiplying. So some of them will damage fertility, but not all of them. So some drugs like cyclophosphamide, which is a very commonly used drug, can damage fertility, but other drugs so for example, vincristine, for example, there's no evidence to suggest that it has significant effects on fertility in later life. But it does depend what drug you are getting. And it also depends on how much you're getting. That sounds obvious. So if you only have a little bit of these drugs, it may not be an effect. But if you have a lot of cyclophosphamide, for example, that can certainly affect fertility in later life. Radiotherapy, as I've touched on, is very damaging to the testes or ovaries. So when I talk about radiotherapy, I'm talking about radiotherapy given to the ovaries, so radiotherapy to the pelvis, or radiotherapy that includes the testes. That can be very, very damaging to fertility in later life. Radiotherapy to the other areas of the body shouldn't affect fertility. You can sometimes get radiotherapy, obviously, to your brain, which may affect the hormones that control fertility and puberty, but these can be supplemented. And increasingly we're using, I put new because some of these treatments have been around for some time now, but we're increasingly using other types of treatments. So immunotherapy is using treatments that help the immune system fight off cancer, or giving antibodies to fight off cancer treatments. And we're often giving things like enzyme inhibitors. So these are things that target growth pathways in cancer cells that can be really, really effective. And I think we're definitely going to be using these more and more over the next 10, 20, 30 years. But unfortunately, we don't know what effects these have on fertility. As I said at the beginning of this slide, most of what we know is based on assessing fertility in people that have had treatment many years ago, and the people that we can assess fertility haven't had these treatments yet. So we can't assume they don't damage fertility. So it's really important we collect data and collect evidence on these newer treatments that we're using. What we can do is give a sort of best guess, excuse me, based on the treatment. So Rod and I and some colleagues around the country put together a document just sort of listing these are the common treatments for these types of cancers. How likely are they to cause fertility in later life? Now, this is very much a guess. These percentages are not very accurate. It's just to give a ballpark figure. And we know that treatment for the commonest cancer we treat, acute lymphoblastic leukemia, most people with standard risk acute lymphoblastic leukemia, their treatment would not be associated with a significant risk of subsequent infertility. But at very high risk are people that, for example, have a bone marrow transplant, for example, depending on what treatment they're given before their transplant, or children with neuroblastoma that's in many places. So high risk neuroblastoma, that treatment is often associated with a very high risk or a very high likelihood of future fertility problems. And as I said, any radiotherapy to the pelvis or testes is very high risk as well. But there are lots of things in the middle where you can't really guess. So non-Hodgkin's lymphoma or standard risk sarcoma, there is a sort of a medium to high risk, but it's really, really difficult to quantify. And that makes some of these discussions very difficult. And it's also really important to remember that many other things can affect fertility. We know that obviously many people in the population have problems with fertility and they've never had cancer treatment. So there are genetic factors, but there are also lots of environmental factors that affect fertility that we can't control. So diet, lifestyle, smoking absolutely is very bad for fertility. So there are lots of other things that can affect this. So what can we do to protect or restore fertility? Well, as I mentioned already, this needs to be thought about before any cancer treatment is given, because we don't really know what damage may have been done, even if we give just a small amount of cancer treatment and then try and protect fertility. So it's much better to be done before any treatment. Now, that may not be possible. So some cancers may press on the spinal cord, or they may press on the airway, the windpipe, or they may threaten vision, and emergency treatment needs to be given. And in those scenarios, often it's not possible to think about fertility preservation. Obviously, as I mentioned, cure is the priority, and we need to sometimes treatment needs to be given urgently. But if possible, options need to be carefully considered and discussed. And that should be based on what can be done, but also based on the likelihood of future fertility problems. So, as I mentioned, many children with leukemia, it's very unlikely that they will have problems with fertility secondary to treatment. So, whilst it's important to discuss fertility, I don't think many people would suggest that we did anything too much to try and preserve fertility, certainly in terms of experimental options that are still under investigation. And it's really important, a basic principle of medicine is don't do more harm than good. So don't cause harm, don't do things that can't be justified. The benefits have to outweigh the risks. So in terms of fertility preservation, there are established procedures, and which we'll talk about briefly, and then we're going to go on to some of the experimental options, particularly Rod's going to talk about some of the research that he's doing. So what's established? Well, for males, the only established, so this has been around for many, many years, it's fully established, it's very successful, is if a male has gone through puberty, they can try to produce a sample of semen to be stored. That can be stored in a special freezer, which can then be used in the future, defrosted and used to make a baby. And actually, because that's established and because it's actually very straightforward to be able to do, I think that should be offered to all males who are mature enough. So they need to be mature, obviously, physically, they have to have gone through puberty, but also they need to be mature enough emotionally. They need to be able to masturbate to produce the specimen, and that might sound easy, but actually it's a very difficult thing to do when you've just been told you have cancer. You're then sent over to a unit usually, so it's not something that's ideal to be done at home. You often have to go to a fertility unit to produce a specimen. That can be very difficult to do, particularly if you've just had a central line in, or you've had some surgery that makes you very sore. It's the last thing you think about doing. So it is difficult to do. There are other ways to get sperm, but many of them aren't ideal. The best way is to produce it with masturbation. And often, especially if you've only just gone through puberty, there aren't many sperm in the ejaculate. So actually there aren't enough sperm to freeze to use in future. And the other really important thing is, and this is a legal thing, that legally, if somebody provides sperm for storage, they have to give consent, so they have to provide permission for that sperm to be stored themselves. They can't ask their parents to give permission on their behalf, and that's because they are sperm that can produce a baby. And that includes going through really very lengthy and sometimes quite frightening consent forms. And one thing on those consent forms that specifically is mentioned is, what would you like to do with your sperm if you were to die? Would you like it disposed of or used for research? That's quite a blunt question to be faced when you've just been told you have cancer. So it's very important that people are aware of that before they go and produce sperm. For females, again, there are very established things that have been used for many years. So if you have a partner, you can produce eggs if you have a sort of you have hormones to stimulate your ovaries to produce eggs that can then be fertilized by your partner's sperm. So this is the diagram at the top right. So you get eggs from the ovary after having hormones, you get sperm from your partner, you put them together to make an embryo, and then those embryos can be preserved specially and then put back into the womb in later life and make a baby. And that's a very established technique and is very, very successful. If you don't have a partner, but you've gone through puberty, so your ovaries can be stimulated, you can just, this is the bottom right, this is basically egg freezing, which you may have read about. A lot of people in the news sometimes try and do egg freezing, which is basically making your ovaries produce eggs, harvesting those eggs, and then storing them in the freezer, and then use them for IVF, so in vitro fertilization, to make a baby in the future. That's a little bit less successful than embryos, but certainly established and certainly works. But both those procedures need the ovaries to be stimulated with hormones to produce the eggs, and that takes quite a few weeks and also isn't very pleasant. You get a lot of side effects from that. And because it takes a few weeks, there's not really enough time to do that when you really want to push on and start cancer treatment. And obviously in children and young people, it's often not really appropriate. I don't think I've looked after any female patient that actually has a partner that they know for definite they want to start a family with in the future. So these techniques aren't really appropriate for the children and young people we care for. The other established procedure, although it's a variable success, is if you are getting radiotherapy to the ovaries, sometimes those ovaries can be moved out of the area or they can be shielded or protected from radiotherapy, but there are a lot of difficulties with doing that, but it can sometimes be helpful. So moving on to experimental options. So this means that we're still learning about them. It doesn't mean that they're not brand new. They've been around for a wee while, but we're still learning about how best to use them. But the reason why we might recommend them, or might be recommended by your healthcare team, is if we don't consider them now, we'll have missed the opportunity. So if you're a child who's 2 years old and your fertility might be at risk, even if we don't know exactly how to use these experimental techniques, in 20, 30 years' time, we are very hopeful that we can use them. So we don't want to miss the opportunity to do that. So the experimental options we're going to talk about, Rod's going to talk about the males and about sort of taking a bit of testis in boys and storing it for future use to make a baby. And I'm just going to briefly talk about taking pieces of ovary from girls before puberty and also freezing them for future use. So for females, as I mentioned at the beginning, ovaries contain your eggs for the future, but before puberty, these eggs are immature. They can't just go straight in and make a baby. But what we can do is take part or all of an ovary. So in younger children, because the ovary is quite small, we often take a whole ovary. As I mentioned already, that shouldn't affect future fertility or age of menopause significantly. Or ideally taking strips of an ovary. So this picture, I hope this picture isn't too upsetting for people, but these are tiny strips of the outside of the ovary which contain some of the immature eggs that can be used for the future. And they are taken before treatment starts. They're specially preserved in a special freezer. And then in many years later on, the plan would be that they can either be transplanted back in to make a baby, or some of the research going on here in Edinburgh is actually, can they be matured in a laboratory to make an egg that can be used to make a baby? And this technique can be done at any age, so this isn't restricted to people after puberty. We can do it before puberty, and actually we've done it here in Edinburgh in very young baby infants. This does, however, require an extra surgery. So this comes back to my point earlier of first, don't do more harm than good. This is an extra operation. Usually it's done as a sort of keyhole procedure, often under the same anaesthetic as putting in a central line for treatment, for example. But it is an extra procedure and therefore is an extra risk. So it should only be done if it definitely is the right thing to do and after careful discussion. But it has been successful. So back in the early 2000s, a group in Belgium demonstrated that they had a viable pregnancy. So they had a successful offspring made by using this technique of preserving parts of ovarian tissue for later life. And similarly, we've done that here in Edinburgh. And actually worldwide, I think more than 200 live births have now been born using this technique. Although I have to say the majority of those were from ovarian tissue that was taken from people that have gone through puberty. Very, very few have been done from girls who have who had it harvested before puberty. But it is something we do need to think about because those techniques are improving all the time. So I'm now going to hand over to Rod Mitchell, who's going to talk about some of his work on males.
Thanks very much, Mark. So Mark has covered very nicely the established options and the approach to dealing with fertility in young people with cancer. But I'm just going to talk a little bit about the experimental work that's being done, both in our lab and also other labs around the world to try and solve this problem of infertility after cancer treatment. So, as Mark said, for those who are already in puberty or adult, the most beneficial option is to try and collect sperm and to store those. And if you can do that, that should be your option. But that doesn't help when we have a situation where we have younger patients, so particularly the prepubertal or very early puberty patients. So those individuals, what we have to do is we have to offer something different. And what we tend to offer them is to store some of their testicular tissue before they have their treatment. So this would be a small operation to take a little bit of the testis, to put it in the freezer and to leave it until they reach adulthood to potentially use it going forward. So we've been offering this now for just over 10 years in Edinburgh, and we've collected samples from a number of patients in this way. But that's, if you like, where we currently are in terms of what we are offering to patients. The next question is, with this tissue that we're collecting and freezing, how are we actually going to use it to restore the fertility? And that's what I'll talk about now, how much progress we're making on this. So these are the main options. You can see that there are three main clinical options for using the tissue that's been frozen. The first is to try and grow that tissue in a dish, so what we call in vitro growth. And for that, we're trying to grow sperm in these tissue pieces that we can extract and then use those sperm for IVF. The other two options involve transplanting material back to the patient after they've had their treatment. And this can either be in the form of transplanting the stem cells back. So as Mark mentioned, it's these stem cells that are what will produce sperm on an ongoing basis, or to transplant pieces of tissue back that you can then again extract those sperm and use them for IVF. So it's either growing the tissue in a dish or it's a type of transplant of the two options. And I'll just talk a little bit about where we actually are with these experimental options, because progress is really being made on these. So we'll start with this idea of tissue grown in a dish to try and generate sperm in these tissues. And this is really where we are with this in terms of using human tissues. So where you've got a patient who's had tissue taken, frozen, you can then culture that piece of tissue in a dish. And a couple of studies here you can see on the right-hand side tell you what progress we've made. So the first one, you can see they've been able to generate cells that look like sperm. They have the morphological or the shape of a sperm with a head, a neck, and a tail. And then on the very far right, you'll see that there are studies where they've shown that you can generate what are called haploid cells. And essentially, haploid means that these cells have gone through the process of losing half of their DNA, so that when they meet an egg, they can join with the half of the DNA from the egg and make an offspring. So it's just showing that these cells that are produced look a bit like sperm and have some characteristics of sperm, but we don't know for sure that these are truly functional sperm yet. So in terms of growing sperm in a dish, we are some way towards doing this, but there's still quite a bit to go. The second option I mentioned is to transplant, and we can either transplant cells or tissue, and I'll talk about each of these in turn. So the first one involves taking that tissue out of the freezer, thawing it, extracting those stem cells from the thawed tissue, and then injecting them into the tubes of the testis. And the aim of this is actually to try and repopulate the testis with stem cells, allow those stem cells to start making sperm. And if you can do that, that may actually restore natural fertility to the patient. So how far away are we from being able to do this? And in fact, there's been more progress on this than there has for the cells in a dish that I mentioned, or the culture technique. So this is a study that was done involving monkeys. This was a study where they basically got testicular tissue, isolated the somatogonial stem cells, transplanted them back into the tubes, and you can see these cells were labeled in blue, so you can see where they've gone, and you can see that they've very nicely filled up all the tubes of the testis. And what happened was, in that testis, it started to make sperm. The sperm could then be extracted from that, injected into an egg, and you can see on the right hand side, this is all the different stages of development of the embryo, right the way through from fertilization into the early stages of embryo development. So this is showing very much that this idea of spermatogonial stem cell transplant using the tissue that's been frozen is potentially a viable option for patients. What about humans? Has this been done on humans? Well, if you'd asked me about a year ago, or just over a year ago, I would have said, apart from one very early attempt, which wasn't particularly well conducted and wasn't very successful, I would have been telling you that this hasn't been done yet for humans in this situation. But that's changed because around about the end of 2024, our colleagues in the US were able to do the first somatogonial stem cell transplantation in a childhood cancer survivor. So the child had had treatment during childhood. They'd had some testicular tissue stored. Those somatogonial stem cells were then extracted when that patient became an adult, and they were transplanted back into the tubes of the testis. And we're still waiting for the results of that. It's still fairly early days to be able to see whether this has actually worked or not. But we're hopeful that this might be the first demonstration that somatogonial stem cell transplant using that frozen material might be an option for patients in the future. So the final option is, again, another transplant type approach, but this time, instead of transplanting the cells into the tubes, what you do with this one is you just transplant the tissue pieces back as whole, intact tissue pieces, with the hope that they will start to generate sperm that you can then extract again and use for IVF. And I'll tell you a little bit about the progress with this approach too. So this again has been something that has been demonstrated in monkey studies, where again they took testicular tissue from the monkey, they transplanted that back into the testis after treatment, and then when you retrieve those transplants after a period of time, it normally takes about 9 months to a year for the sperm to be made. You can see that in this study, the testis had actually been able to make sperm. So that's proof that this approach might be able to make sperm. But in fact, they've gone a step further than that. And this again is the group in the United States who did a study again using monkey testis. And with this one, again, they transplanted the tissue into the testis. They were able to extract the sperm from those transplants after around about 9 months to a year or so. And then they injected the sperm into the eggs, and you can see the figure of on the right-hand side of where they've injected it. It's generated an embryo, and beautifully at the end of this process, they were able to have a live birth from this approach. And this was the first demonstration that this really potentially is going to work for patients. This monkey is called Grady, She's called Grady because she's graft-derived baby. That's where her name comes from. And she's a very happy, healthy rhesus monkey. She's actually now 7 years old and is living her best life in the States. So this really shows that proof of principle is really there, certainly for the testicular tissue transplant, for taking this into human studies. And in fact, again, if you'd asked me about this a year ago, I would have told you this hasn't been done in humans, but I now have to tell you that it has been done. This is a group in Belgium who have done the first testicular tissue transplant in around about January, I think it was, of this year. And so again, this is a method which is potentially going to be available to patients in the future. Again, we still are waiting for the results of this trial because we need to wait for enough time for the sperm to be made and then for it potentially to be used. But it's really very good news and very promising, the progress that's been made in the various different ways of trying to restore fertility in these patients. And just really to end with the whole research side of this for the boys is to tell you that we also have now open a UK trial to transplant testicular tissue back to patients. This was approved back in 2023, and we are in the process of recruiting patients to be able to do this for our patients too. And as I say, we still haven't had a successful transplant in terms of being able to produce sperm yet in humans. So we're hoping that this will be somewhere on the horizon. So hopefully that gives you a little bit of a feel for some of the experimental work that's being done, and also just so that you can appreciate that progress really is being made on doing something for patients, particularly for those who've had tissue stored as children. So with that, I will hand back to Mark, who's going to finish off the rest of the talk.
Thanks, Rod. Yeah, so I just last thing I just wanted to mention is about sexual health, because I think there can be some confusion. So it's important to remember that fertility and sexual health are different. So your fertility can be affected, but you have normal sexual health. Equally, you may have problems with sexual health, but be fertile. So they are very, very separate. And we do know, again, from lots of studies that many people who have been treated for cancer do have difficulties with many different aspects of sex. And the reasons for this are actually very poorly understood. Unlike fertility, that you can often relate to a specific part of treatment, there are lots of other aspects that can affect sexual health. And as I say, they are poorly understood, and I think we do need to learn much more about them. So it's really important to talk to your healthcare team about this. And it's really important that people are followed up long term, because these issues sometimes arise many, many years after treatment for cancer has been completed and there are no concerns about cancer coming back. But it's really important that we think about you getting on with your life and doing all the things that you want to do. So that's why I wanted to mention that. So I know we've given a lot of information. I think it's really important that you sort of talk to your healthcare team, and your healthcare team should talk to you about these issues, about fertility and also about sexual health. There is also a lot of information online. So the Children with Cancer UK, Teenage Cancer Trust, there's some stuff on YouTube that's quite helpful. And obviously the CCLG website has some very good resources in this regard as well. So there are many, there are lots of information out there, but I would recommend just using sort of trusted sources of reliable information. But thanks for your time this afternoon, and Rod and I are very happy to answer any questions. Thank you.
That was brilliant, thank you. Like, a lot going on. It sounds quite an exciting time to be in your field, really.
Absolutely.
We don't have any questions yet, so I figured I'd start with one of mine, if that's okay. So I was just wondering if you knew why fertilized eggs/embryos are more stable, like why that's more successful than just freezing eggs.
Yeah, so I mean, I think the eggs we're storing from the ovary, many of them are quite immature, so they don't survive some of the sort of freeze-thaw processes that we do. Yeah, I mean, I'm glad you asked that. It is interesting, but how an embryo, a fertilized embryo, definitely survives freeze thaw better than just an egg, and definitely better than immature eggs. So so that's why that's established. But as I say, it's not really a very useful technique in the people we look after.
Thank you. And we have another question that's not from me. Is there any evidence that cancer treatment causes difficulties in the offspring of children who've had cancer? Like, so can it damage the eggs to the point that they would damage a future child, I guess?
So
Sorry,
what's that question?
Can you repeat that? Sorry, Ellie, we couldn't quite. Sorry.
Sorry, so is there any evidence that cancer treatment causes difficulties in the offspring of patients?
So that's an excellent question. I'll maybe go and you might want to add to that, Rod. No, there isn't any evidence, but it has been looked at a lot in terms of are we damaging sperm or eggs? Are we affecting which sperm we use for fertilization? But there's no specific evidence to suggest that that is going to cause any problems with the offspring. But that's an excellent question.
Yeah, I think it's a fair point. We don't have evidence to suggest that's a problem. Yeah.
Okay. And there are more questions. I knew there'd be a lot of questions today, so they were just having a slow start because he gave so much information. So how safe is it to transplant tissue back to patients after conditions such as leukemia? Can it reintroduce the disease?
Yeah, that's an excellent question, and it's something that we very much consider. You're absolutely right. The last thing we want to do is to take tissue, either ovary or testes, from a patient with cancer, treat them for their cancer, and then in transplanting tissue back in, we give them back their disease. That would be a disaster. And so it's an excellent question, and it's something that we would be concerned about. I think it's one reason why in somebody with ALL, we wouldn't be recommending harvesting tissue, and that tissue, if we did harvest it for whatever reason, it would never be transplanted back in, because we know that the testes and probably the ovaries are what are called sanctuary sites. So we know that leukemia cells do get into the testes and the ovaries. So however, we do know that some people might have fertility affected, and we still want to try and offer something to preserve fertility. So that's why some of the techniques that Rod's working on, and also the other lab here in Edinburgh, is looking at, can we mature the cells in the lab and make a sperm and egg that can be used for fertilization? Therefore, we're never going to be, we wouldn't transplant that tissue back in, we would mature them in the lab and use them for fertility. But that's an excellent question, Rod, if you want to. And also I should say that the study Rod's saying is part of it would be making sure that there are absolutely no cancer cells in any tissue that's transplanted back in.
Yeah, that's true. So any patient with a malignancy where we're considering transplanting the tissue back, we will have careful processes in place to ensure that we're not putting back any material that has malignancy. But as Mark said, a condition like leukemia, we wouldn't be putting that back because the risk would be too high. But there are other options that don't involve putting it back. And the patients with leukemia who are standard risk, as Mark said, they have low risk for fertility. It's maybe the group that have had initial treatment and now have relapsed and require a bone marrow transplant. Those are ones that we might think about collecting tissue, but we wouldn't be putting it back.
Okay, thank you. I have another question on acute lymphoblastic leukemia while we're here. Is there any evidence to suggest that chemotherapy for childhood cancer can cause issues with delayed puberty?
So again, the question, Roger, as an endocrinologist, you may want to answer that one.
Yeah, so as Mark said, in most cases of cancer treatment in general, even if the germ cells and fertility can be affected, normally puberty progresses. So in the vast majority of cases, puberty will progress. They'll make testosterone, they'll go through puberty. So for most cases of ALL, particularly if they've not had a bone marrow transplant or more significant treatment other than standard risk treatment, we wouldn't expect that the treatment would cause significant issues with delayed puberty. One of the problems we have is that actually delayed puberty is quite common in boys, for sure, regardless of whether you have had cancer or cancer treatment or not. So it's very common to have delayed puberty anyway. So in most cases of patients who've had cancer who have delayed puberty, it may actually be that it's not the cancer or the treatment that's necessarily that's done it.
Okay, thank you.
Worth adding, we also know that some tumours and treatments can affect the timing of puberty in terms of the hormones that control puberty. So actually sometimes we get children who have early puberty for whatever reasons, and that also needs to be managed, as well as delayed puberty. So pubertal timing of puberty can be affected by tumour and some treatments, particularly radiotherapy to the brain.
Radiotherapy to the brain, yeah.
Brock, you've sort of gone out of frame a bit.
Oh,
Actually, you both have. Sorry, could you both scooch in a bit? Thank you.
We'll get cozy.
Yeah, we do like each other.
I have a whole load more questions, if that's okay. So somebody has asked whether I've lost it. Whether if the eggs weren't harvested before treatment, whether there would still be an option after treatment if they still have them there, like if they're a young teenager.
As in harvesting eggs afterwards, after treatment?
Yes, if like to preserve them for later life, I guess.
So that's a not uncommon question. And again, an excellent question. I think something that's important to sort of talk to your team about. So as I mentioned, we know that the eggs go down quicker when you've had certain types of chemotherapy, or if you've had radiotherapy. So there may be a good argument for trying to sort of harvest them and freeze them before they go down, before it's too late. So it's definitely something that you need to discuss. Obviously, one thing we don't know enough about at the moment is what effects in terms of the treatment you've had, what effects those treatments will have on the eggs that you're harvesting, which is why if fertility is going to be at significant risk, it's much better to harvest tissue before any treatment starts.
Yeah, and it's not common practice to harvest eggs after treatment as an option. And I think if there's concern about fertility reserve, then one of the things that is sometimes said, and this is obviously this is a difficult one to handle, process in a way, but sometimes if there's concern about fertility, is some of the clinicians will talk about considering when you want to have your family, and considering sometimes having it earlier rather than later if you want to have that, because of that risk. But obviously that's a very sensitive thing to discuss, but sometimes that's is a discussion. But generally speaking, we don't do fertility preservation after treatment's been completed. Is that fair enough to say?
It's better done before.
Okay. So another question about tissue samples. Do you need patient consent to take the tissue samples? As I know you said they need consent to sample storage. And is this procedure only available at specific hospitals?
So yeah, good question. So in terms of, I mentioned about sort of semen storage, and if you store sperm, you have to give consent yourself because that's a gamete. So the law I was referring to is the Human Fertilization and Embryology Act. So if you are storing mature gametes, so mature sperm or mature eggs that can undergo fertilization, that has to be you giving consent because they're yours. But if it's immature tissue, then actually that is covered by parental consent or consent by guardians. So parents and guardians can consent for the harvesting and storage of immature sperm and eggs. But obviously, if it was used in later life, that has to come from the patient themselves. So if it was ever to be used to make a baby in the future, then absolutely that would have to be the person themselves that gives consent.
Yeah, and the only other thing to add to that is quite often the young people are not of an age where they can consent themselves, so the small children can't do that. So if the parents have done the consent on behalf of the child, we would normally get those individuals back between 16 and 18 years of age and reconsent them, so they take over, if you like, storage of their material once they become old enough to make that decision. And then beyond that, it's all their decision as to what happens.
Okay.
And I think the other part of the question was about where this is done. So in Scotland, all the tissue harvested in Scotland is stored in Edinburgh, but we now have arrangements with other hospitals in Scotland that it can be taken with a surgical operation in other hospitals, but then transported to Edinburgh. And I think in England they have a sort of similar system with Oxford, and I think London being the main areas. But it can be done in other hospitals.
Do you guys have anything that you have to get to? Because we've got about 7 questions left, so I just want to check that you don't have meetings straight after this.
I'm seeing a patient soon, but I can hang on for a little bit longer. That's fine.
Okay, I will try and filter down. I'll go to attendees. We've got a couple of questions that are specific to their children. So obviously the advice would be best to talk to your care teams, as Rod and Mark can't give specific advice. If that's okay with you both, obviously. Yep. Okay, so the next one, I think is a nice quick one, is the testes material that you're going to reimplant. Where are you going to reimplant it? Will it be in the testes or in another part of the body?
Yeah, so it's good, very good question. So there are 2 options. The first is just to put it underneath the skin. And the best way to do that, best place to do that is in the scrotum, so the sac around the testicle. And then the other option is to just make a little opening in the testicle itself and put that bit of tissue back in. So both of those sites are being used as an option. And the animal studies that have been done show that you can actually generate sperm using both of those sites. So either in the testicle or just under the skin of the scrotum are the 2 main places that the tissue will go back.
Thank you. And the next one is, so this person's a little confused because they said, you mentioned acute lymphoblastic leukemia being a low risk of impacting fertility, but also that it could be present in the reproductive organs. Does that mean that future embryos would be affected?
No, when I say that, I mean there can be leukemia cells in the testes or the ovaries, but they shouldn't affect the function of the testes or the ovaries. And the treatment for leukemia is generally associated with a much lower risk of subsequent problems with fertility.
Okay, thank you. Right, what are we doing next? Sorry, I've got questions coming from 2 directions, so I'm trying to find the right one. So how long can tissue be stored, and do you have to pay? And then as a bonus, I'm going to add on another question to that bit of, is it accessible to go through fertility treatment via the NHS, or are people having to pay?
Yeah, so the tissue can be stored for up to 55 years. So for most of us, that will be as long as we ever would want to be using it for. And it's you don't have to pay for the storage currently. And that's the main centres that are offering this and storing it without any payment needed. So and then the second part was about
how accessible it is to go through like IVF with the NHS.
Fertility, yeah. So you would be able to get IVF using that material according to the same eligibility criteria that anyone would have for IVF. So the expectation there is that there would be the option to be able to use it for IVF without having to pay for that privately. But it would need to meet all the same criteria. So in terms of number of cycles that you could have, eligibility in terms of age, etc., etc. So essentially, it puts people in the same boat as other people who are facing fertility treatments, if you like. You're not disadvantaged if it's because you had cancer or cancer treatment.
Okay, I think we have 2 more questions, and then I think we're going to have to call it a day, if that's okay. So one question is, does putting the ovaries back help with hormone treatment or hormone replacement?
So absolutely can. Some people have done that. I think our view would be that actually if you've taken ovaries to restore fertility, it's very precious and is best used to restore fertility, because you can have hormone replacement therapy to help with hormone treatment. So yes, it can help, but I don't think it's the best use of this tissue, in my opinion. I think it should be used for fertility.
Yeah, agree. And just to add as well that the transplants will potentially only last for a certain period of time. It won't necessarily be, lifelong replacement of hormones either. You might need to have more transplants to be able to do that. So it's not something we typically offer as a way of replacing hormones.
Okay, thank you. So the last question, which I think is a nice note to end on, is you mentioned that learning fertility has been impacted by cancer can be distressing long term. What can parents do to help sensitively prepare child cancer survivors for this?
So yeah, I think that's a really good question and a really good point, and I think it comes back to the importance of open and honest discussing a diagnosis to explain what problems might happen and what can be done about it, but also in long-term follow-up, making sure that fertility is discussed in follow-up. It's assessed when a patient wants it assessed, and what can be done should be offered. I think that's really important. I think it's important to discuss fertility during follow-up, not just because of the significant distress that being infertile can bring, but also to make sure that I mentioned that you don't assume you're infertile. I mentioned high-risk treatment that is often associated with problems in fertility in later life, but there are many case reports of people that have, I mean, I've seen patients who I would be very surprised if they were fertile, and actually they are fertile. So never assume you're infertile, and if you don't want to start a baby, definitely use contraception.